Hey, I'm Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC. And one of my big ideas through this podcast is to generate one-on-one conversations. I'm looking for smart, engaged people who have inside knowledge and observational point of view that can say, hey, here's something that maybe we could do better. How can we optimize patient care in our region? And today I'm really grateful to be joined by James Heilman. He's an emergency room physician at the East Kootenay Regional Hospital in Cranbrook. And I've been lucky enough to have a colleague or two on from my neck of the woods in the West Kootenays, but it's time that we got some balance and heard how things are on the other side of that mountain range. So, good day to you, James. How are things in Cranbrook today?
Yeah, James, thanks for having me. Great to be here.
Well, sweet that you could take the time to join me. So, why don't I just ask you to open and give us a little sense of how you got to this point in your life journey. Where's James' roots and how did you end up in Cranbrook doing what you do today?
Yeah, so I grew up a couple of provinces over in Saskatchewan. I'm a farm kid. Went to high school in Saskatchewan, went to the University of Saskatchewan for medicine. And I have a great love for the outdoors, great love for the mountains, even though I didn't grow up with them. So I came west for residency. I did residency here in British Columbia. Went back to Saskatchewan for 5 years, and then my wife, who also loved the mountains, and she brought me back this direction to Cranbrook. So I've been in Cranbrook now for the last 15 years.
Oh, that's cool. Yes. And enjoy one of the highest rates of sunshine of any small city in Canada, basically, eh?
And some fabulous mountains.
For sure. Hey, so what would your current state of kind of healthcare in the East Kootenays assessment be? Like, as you just look out, maybe you're thinking about what you're going to do at your shift the next time you have to go, or what you've been experiencing in 2024. Where's healthcare at in the East Kootenays these days?
Um, so there's been some pluses and minuses over the last decade here. Um, on the plus side, we got a permanent MRI at our hospital, which has made a tremendous difference to our patient population. We've got a brand new, incredibly beautiful ICU. Um, uh, but on the negative, you know, we're in need of a new merch department.
Right.
We, as so many places, struggle with a lack of long-term care beds. And that's, I'm happy to speak on that further, but that's probably, our number one biggest issue within healthcare in our community, if not, across 90% of communities in British Columbia, if not all of Canada. Um, and then, we, like so many areas in rural British Columbia, we struggle with transport. We've made some good progress in transport, but there's still, more effort to be put into this area of what we do.
Okay, well, why don't I just latch onto that one because that one's near and dear to my heart. Maybe just set the scene a little bit for the average citizen who hasn't had to deal with the healthcare system a lot. What does transport really practically entail? What are we talking about? To where, from where, that kind of stuff. Give us a little more there.
Yeah, so if you show up to one of our mid-sized hospitals in British Columbia, you do not have the whole gamut of specialties. You don't have the whole gamut of access to specialties in that hospital. And medicine has become more specialized over the years, not less. The generalist has gone the way of the dodo bird. And thus, many times you can show up to our hospital and there will be no urology, there will be no ENT, there will be no ophthalmology. There never has been neurosurgery. There's no cardiothoracic surgery. So if you're needing one of those subspecialties, you're just simply out of luck. And that means that the physicians involved in your care needs to figure out a transport plan for you to, get you to where that service is available. Now, in our neck of the woods, transport is incredibly complicated. Even though we have these stunningly beautiful mountains that, are wonderful on a nice, bright, sunny day, when the ice winds come in, and, when the roads, turn to skating rinks, it can make travel incredibly complicated. So it can be tough for helicopters to fly in. It can be tough for fixed wing aircraft to fly in. Our airports themselves, you need to have someone on the ground to clean the runway. You need to have someone on the ground to de-ice the plane. There's all these, and of course these resources exist during daylight hours for commercial airlines. But, we're talking about, having these folks on call, being able to get a hold of them, and being able to keep this aspect of the transport logistics up and running. And then, so for time-sensitive issues, transport can be difficult. So we will often run through, you often need, your first line option, your second line option, your third line option, your fourth line option, as, the ideal options end up falling by the wayside. And sometimes, you end up making very difficult decisions about, what is the least risky option to choose, because there is no ideal option in many of these situations.
Would you say that predominantly we're talking about transport to Kelowna or Vancouver? Or I know historically also, sometimes there was transport to Lethbridge or Calgary out of your neighborhood, but that kind of changed when the Alberta government was much more resistant to receiving BC patients, as I recall.
So, we thankfully still do have a pretty decent relationship with Alberta. They are still, they're still our primary referral center for those who need to receive care within, the next couple of hours for a life or limb reason. So, they will accept our, for folks who have a really big stroke, who need to have surgery to treat their stroke, Calgary will take those patients, pending, Alberta's ability to fly. So going back to that transport option, we will occasionally, of course, send these folks by road as well. So, they will take our major traumas, they will take our acute strokes, they will take our failed thrombolysis. So there still is, even our retinal detachments, we'll be sending those people to see ophthalmology generally by ground in the Alberta direction, because that's substantially faster for citizens in this community than going to Kelowna. One of the other benefits we receive from Alberta is STARS will do auto launch to Cranbrook and further east. So if you are in Sparwood, Elkford, they will pop over that one short little mountain range, land in Sparwood, Elkford at a car accident, pick you up from the scene of that car accident if those resources are available, and then fly you directly back to Foothills Hospital, bypassing many of the little communities who don't have the resources to manage, your potential injuries.
That was something, so back in the day, I worked and lived for 8 years in Olds, Alberta. It's an hour north of Calgary. Usually the road works, but even if, say, it doesn't, I can remember, shock trauma air rescue systems, the helicopters just landing on the pad, boom, 1 hour, it was done. And honestly, as much as I love living in Nelson, it never occurred to me before I lived here how hard it was going to be to get a helicopter to land where I am, or to plane to Castlegar, or any of these other things. And we don't have that option. I'm actually glad to hear that you still do, because I had heard some, rumor to the effect that was being limited a bit. But at what percentage of the days of the year when maybe they can't fly, do you think, or that it doesn't work out?
The winter season, they're less able to fly. So, they generally can't fly due to two reasons. One, the aircrafts are already out on another flight taking care of another patient, and they're simply not available. And two, the weather just doesn't permit them to fly, and the pilots deem flying to be unsafe. And Alberta is able to fly with instruments with their helicopters, um, the ability to do so is more limited than when the sun's shining. So yeah, if we have low-lying fog, if it's a snowstorm, if there's issues around icing, then that can limit the ability to get the helicopter in. And then, you're looking at the second line, which is fixed wing. Fixed wing has a greater capability to fly, but, that capability isn't endless either. We're all aware how often WestJet and Air Canada cancel their flights due to weather. Of course, the same cancellations definitely happen to air ambulance as well.
Do you think, I remember being on a phone conference one time with someone from Vancouver who was kind of speaking off the record, but he was saying that we really should, through patient transport network that we have in BC or the BC ambulance service, have more fixed wing or similar resources based out of Cranbrook. Is that something where you're like, yes, people do talk about that and we should, or do you feel like we're resourced appropriately? I guess what's your assessment or your colleagues' assessment of that kind of things?
Yeah, we have increased the number of aircraft that BCHS is operating and contracts to. Um, one of my hats includes providing advice to BCHS. So I'm one of their EPOS physicians, and it doesn't really matter so much where the aircraft is based. I did a fly around with them one day. I started in Vancouver. We took off. We flew from Vancouver to Prince George. We flew from Prince George to Fort St. John. We flew from Fort St. John over to um, um, Prince Rupert. We never went back to Vancouver. So, we were in Vancouver at the beginning of the day, we're in Vancouver at the end of the day. So it's not like, you have an aircraft stationed in a place and that aircraft is there to serve that community. The way the logistics of the air system works in BC is you take off in the morning from wherever, and then you spend the entire day, doing flights all around the province in whatever way makes the most sense. And, a lot of folks try to compare the BC ambulance service with the Alberta ambulance service. And, BC is so much more complicated than Alberta. Like we have all these small little towns and we have all these accepting regional centers. Um, and, I called STARS one day and I'm like, I have a patient I want to send to Lethbridge. And STARS' response is, we don't do Lethbridge. We only do Calgary. If you want someone brought to Calgary, we're happy to help. Really? And I was like, wow, what a simple transport system. All your airplanes start in one city, and after the end, and they only bring patients back to that one city. You have one spoke, or you have one center area, and then spokes going out from there. And in BC, we have regional centers in Kelowna. We have regional centers in Victoria. We have regional centers in Nanaimo. We have regional centers in Prince George. So we have so much more complexity. And, Alberta only has, a dusting of mountains near the border. And we're mountains from top to bottom, left to right.
I grew up in Alberta being used to kind of just, hitting the cruise control and driving in a straight line to the next town for 1 hour. And we don't not have that reality. So aside from the fact that obviously we live, work, and play here and love being near all this amazing outdoor stuff, which also has the flip side of it being, kind of geographically challenging for transport systems. Is there anything you think as a system we should do better or more? Because I appreciate that you wear these different hats. Is there something where you're like, oh yeah, couldn't we just do that? Or you feel like we're making the best of whatever we have?
One massive improvement we have made over the last 10 years is we've put together the heart teams. You of course have one based out of Trail. We have one based here in Cranbrook. And it's basically, a team of a highly trained nurse, a highly trained paramedic who have the expertise of how to work in the back of a ground ambulance. And they're sort of supplementing the BLS or the low level ambulance teams to move complicated patients within our region and between our region and other regions. So they have been, a godsend because, 15, 20 years ago, the expectation was that doctors would jump in the back of ambulances, with a little bit of gear that they out of their usual environment. And, that was an incredibly stressful situation for, the physicians and healthcare providers in question. And now that we have these dedicated teams, and, these teams have been fairly well resourced, this has made a huge difference to keep, both physicians and nurses in their own communities.
I was lucky enough to have done an episode with Lisa Keach, who's one of our coordinators here. And I appreciate Lisa very much. And you're right. I think it's something like 100 days of the year, one quarter, a little more than one quarter of the days of the year, Nelson has the heart team come and visit our site because
Yes.
we need somebody to be moved or we need help. People are going up to an ICU level. And I suppose from your emerge to ICU is down the hall. But you still have people who need to get to a critical care specialist of some other kind, and they have to be moved.
Yeah, so the heart team is involved in transporting high acuity patients from our hospital to the 30 minutes to the airport. Cut down, and that decreases an hour transport time for the patient as the fixed wing meets them at the airport, rather than the critical care crew driving in from the airport to the hospital and then back again. And then, of course, our team is going out and supporting, the smaller sites around us and bringing patients to our ICU here in Cranbrook. And, occasionally, the heart team is carrying people all the way from here to Calgary when, helicopter and fixed wing options fall through.
Okay, so your heart team will cross the border and will make the full drive and do what they have to do. Okay, that's a long day for them.
Yeah, I know there's some dedicated professionals, and they're sometimes putting in, 16, 18-hour shifts to do what needs to be done to, give folks the best care possible.
Right. And then, so what's it like? Your role is a little bit different than mine because effectively Nelson is a primary care hospital. I mean, we have obstetrics and gynecology and some visiting specialists, but you serve as the regional site for all the way Radium, Invermere up and then down Creston and Fernie, all those other places. What's it like to be the emerge doc at the regional hospital? Is that something that you're just so familiar with you don't think any different of it? Or do you think that your role has some kind of unique twist on it? I'd be happy to hear your take on that.
You're getting a lot of phone calls. So there's a lot of interruptions during your day, as you're the accepting physician for this massive quantity of imaging that's ordered. The number of CTs we do, the number of MRIs we do, the number of ultrasounds we do has all increased quite substantially in quantity, as this imaging is becoming more and more the standard of care. Like I remember reading a paper out of Calgary not that long ago, and they're saying 40% of people who go to Foothills Hospital leave with at least one CT.
Wow, eh?
And so, we're the only CT in our region. With respect to improving care, it is now the time where, any town with more than 5,000 people should have their own CT scanner. Nelson, of course, you guys now have a CT scanner. It's been how many years now? It's been quite some time now.
Well, you're absolutely right. Like we did some special fundraising back in 2011, 2012, and our CT scanner is 13 years old now and is having some breakdowns, and we need a new one. And so one of my follow-ups to you was, well, if we need a new one and Golden needs one and Burnie or Invermere or wherever else you designate is a good idea, because I get it, they're geographically diverse. Do we just bite the bullet and everybody gets one and we got to do that? Because I'm
100%.
open to
Yes.
that. I'm very open to that.
We definitely need, we definitely need to have all these towns having easy access to CT. that's just deemed to be part of medicine now. And all of our new docs coming out of training, none of them have worked in an environment where there's not easy access to CTs.
Right.
That's part of the reason why some of these smaller communities struggle to recruit physicians. Is all of a sudden here you are, you're coming out of your residency program, and all of a sudden you're pushed into this austere environment, and you don't feel like you can give patients the same care you gave them during your training because you don't have access to what are now basic tools for practicing medicine, which is a CT scanner.
What about have you done any research or understood about the possibility of like smaller sort of mobile units? Is there anything that has been talked about in the East Kootenays about, even if you had one for head and neck only, or you had something that could be moved around? I'm mostly just trying to use creative lateral thinking right now, but I'd be happy for
Yeah.
everybody to have what they need.
Yeah. We used to share our MRI with Trail. And
Right, right. It was a
and
trailer and it moved back and forth.
yeah, yeah, exactly. Um, I'm like, I'm, I'm not convinced that is because everybody like you really just need it to be there.
Yeah.
You need to be there all the time. Um, um, you know, and the complexity, I don't think, is the one-time cost of building the room to house the CT scanner and buying the CT scanner. I'm sure they're much less expensive than they used to be. Um, as everything technology related comes down in price, I imagine, the bigger complexity is, getting the staffing, dual training your X-ray techs to also be CT techs, and making sure that you have that staffing on call so that you can run your CT 24/7. But having that access would substantially cut down on transports, because I wouldn't be surprised if 50% of our ambulance transports interfacility are primarily related to imaging questions. And plus, it will help patients get to where they need to go faster. Like, if they had a CT scan in Invermere and they were able to CT scan someone's head there after a ski accident, they could say, do I fly them directly to Calgary, or do I send them, do I just send them home? But instead at this point in time, they go from the ski hill to Invermere. They come from Invermere to Cranbrook by ambulance, and then we scan them here in Cranbrook, and then we're making that decision: do we fly them to Calgary because they have an intracranial bleed, versus do we send them out and do they need to figure out how to get home? Because that's the other complexity is, the ambulance is technically only providing people with a one-way transport to a higher level of care. The ambulance service doesn't provide return visits.
Oh, that's so true. And I lived
And
that on a smaller scale.
and so many patients don't realize that, and they end up stranded, and they end up very upset in in the regional center, because now they're struggling to figure out how to get home after they've had a scan that clears them of the medical concern for which they were sent down, and they can now be discharged home.
I'm just old enough where the first 10 years of my career was basically practiced without a CT scanner, and I got kind of comfortable with it. But that's 15 years ago now. And, I'm not really able to talk to a surgical specialist on the phone without my second summary point being what the CT shows, because they expect that.
Mm-hmm.
No one is interested in me ruling in or out their stroke without a CT, and the list goes on. So, I'm really glad you brought this up, because I think individually communities could totally band together, could fundraise to make sure we had the latest, greatest equipment. What we need the health authority for is to house it inside the facility and to find, like you said, a combined X-ray CT tech.
and
But
the
I
staff.
have the sense that the health authorities' bureaucracy is kind of slowing us down on some of these things. And maybe ultimately it comes from the Ministry of Health, but I don't know. Do you have any takes on that? Are we missing the boat as a great big collective society and how we allow these decisions to be made?
I think the biggest concern from the health authority, I'm not sure if this is true or not, is that they're worried that there just simply doesn't exist enough CT techs. And, if they triple the number of CT scanners, where are they going to find the people to run this? And it's like, so we need to dramatically expand the programs for CT techs, so that we can dramatically expand the number of CT techs in existence, so that, when we do put in all these more of these CT scanners, we can then staff them.
Well, we better get at her.
So yeah, do we need, a program for CT techs, at the college here in Cranbrook? Do we need one at the college in Trail? I think we do. We have a nursing program now. We need to be training a lot more healthcare providers.
Yeah. Yeah. And people don't have the necessarily 40, 50-year career, and things have shifted and changed so much that we're just dealing with a new landscape. It's not the 1990s anymore, is it?
Yeah. Yeah. It's physicians don't work the hours that they used to.
Right.
And female physicians work, less hours than male physicians, per numbers, within Canada, due to various reasons. And, my class, when I graduated from medicine 22 years ago, was already greater than 50% women. And it's been more than 50% women ever since. So, I don't know whether we've already reached the majority female physicians. I imagine. But so, we just need proportionally more physicians to do the same number of hours of work.
And the stats on younger male physicians is the
Yeah.
same. It takes two
Yeah.
of the folks who are coming into practice now to replace one of those long-serving
Yeah.
wide
Yeah.
panel.
We have we only have one ENT surgeon who's want to work weekends. And is he in his late 70s, early 80s now? But he's the one we call on Saturday and Sunday, because our young ENT folks don't want to work weekends.
I mean, it's a reality, and we've sometimes seen the troubles on the other side of it. If work is your only
For sure.
angle, it's tough. Yeah.
Yeah. Yeah. And those folks, they don't exist anymore.
Yeah. Welcome to 2025. We have
Okay.
to adjust our calibrations, and we can't be using old models the way we thought we could for a while.
Yeah. Yeah.
Hey,
Yeah.
you mentioned long-term care beds, so I hope this is some kind of a segue. Um, what what do you see as solutions? Because what ends up happening, as you're well aware, but perhaps not everyone in the public knows, is folks spend excessive time on the medical ward when that's not really the best place for them. They should be in a long-term care bed. And then there's domino effects working backwards in the system to where then some admissions have to stay in emerge because they can't go up to the medical ward. So what do we do to get more long-term care beds or help those folks who are currently unable to get back to the community thrive in a place other than our medical wards?
Yeah. So as you stated, there's this domino effect. The long-term care homes, once they fill up, they can say, full stop, we're full. You can't send us anybody else. So those patients then sit within the acute care wards of our hospital. And the acute care wards of our hospital they have a hard barrier where they hit a certain number of patients, and they're like, I'm sorry, we're full. We're not taking nobody else. And then the patients end up in the emerge department. And we will have patients in the emerge for 24, 48, 72 hours. And, that is taking, we only have 14 beds in our emerge department. And, you end up with 6, 8 10 admitted patients, and not only are they, taking up acute care um, emerge beds, but they're consuming the nursing emerge staff, and the nurses are like, well, we only take care of 5, 6 patients at a time. The patients in the waiting room aren't our patients. And then all of a sudden, as a physician, you're trying to treat patients in a non-care environment, i.e. the waiting room or the back hallway, with zero nursing support. And it's like, so those up the chain, they they don't have they don't deal with the repercussions of them not managing what is within their wheelhouse. And if they can just simply put up their hands and say we're full, and and then ignore the repercussions that are occurring into other areas within the healthcare system, in my opinion, that's not fair. We as emerge docs, we as emerge nurses suffer the moral injury of all of a sudden not having the resources, and then the population, they're funding these emerge departments that are no longer working as an emerge department. If we're full of acute care patients, you no longer have an emerge department. Um, and that's one of the reasons why emerges have become so inefficient and have such long wait times. It's less so people coming in with minor complaints. Those don't take a lot of time. You think a minor complaint 5 to 10 minutes, but you think an admitted patient for 72 hours in your emerge department, you divide 72 hours by 10 minutes, and that's a lot of, you can see hundreds of people with minor complaints for, the amount of resources that one acute care patient has taken within your emerge system. So, we're a siloed system. The long-term care system is not part of the acute care system. The leadership of the in-hospital care teams is different than the leadership of the emerge teams. So we have these different groups, and I'm not sure how to, incentivize folks. There's little tweaks you could make, but I think what it comes down to is, we need another 1, 2, 3,000 acute care beds. That's the solution. There is no other solution, and we can move the decks around on the Titanic, but unless we fix that gaping hole, unless we figure out how to create safe living environments for all these individuals who can no longer safely live at home due to various reasons, we can make a few tweaks by providing better home care, because there's a small population who are in long-term care who could maybe live at home, but there's still this very large population due to mobility issues, due to cognitive issues, who just simply cannot live at home.
Yeah, I think you've made a bunch of valuable points there, and absolutely, I echo that one of the main problems for inefficiency in emerge is how many admitted patients so many of the larger hospitals have, and then that filters down to your level and my level, and that it isn't about minor complaints. We'll get to all those people eventually, and they can be seen fairly efficiently. And I read a stat the other day that said that of developed economies in North America and Europe, I think Canada has one of the absolute lowest rates of acute healthcare beds per population. And that's just not workable anymore. And if someone wants to come up with a magic innovation where as a society we do, I heard of a program in the Lower Mainland called Hospital at Home. Well, if we're going to all as neighbors and friends and public health officials support that, very good. But if we're not coming up with innovations in those regards or finding them workable, then we got to actually have more space in our actual facilities, because creating more and more efficiencies, we squeezed the juice out of that stone a long time ago.
And before building more acute care beds, we need more long-term beds.
All right.
You know, I think that's where we should really be putting the effort, because right now, 20% of our acute care beds are holding long-term care patients. So we can easily, yeah, and it's much less expensive as, a government to create long-term care beds than it is to create acute care beds. But, we should have zero long-term care patients in acute care. And then if we still don't have beds, that's when that's when we know we need to start building them. But, if we have acute care beds with long-term care patients in them, we need to get those folks to where they're better managed.
Right, because it's a misappropriation. Yeah, I totally get your point there. Yeah. Wow, I mean, so many things to fix, but I'm enjoying how this conversation's going. Hey, on a slightly more novel side, I know of you from the past when I've seen video clips on the internet of you solving all of Wikipedia's problems. Tell me a little bit about your history with Wikipedia and all the work you've done in that regard.
Yeah, I don't know if I've solved all their problems, but I've tried. So yeah, I've been involved in the Wikipedia movement since 2007. I got involved. I was working a night shift in the Emerge department. The Emerge department was quiet. I was looking around the internet. I came across this website that wasn't very good, and then I noticed that there was an edit button. And I realized that I could fix the internet. And that sort of like it reeled me in. I realized just how many people, were turning to Wikipedia as a source of healthcare information. So yeah, I've spent a good portion of the last nearly, I guess it is almost 20 years now, working on and within the Wikipedia movement to improve the quality of their healthcare content. So it's
And are we
been,
at a good place now? Are you satisfied with the amount of progress that's been made? Or?
um, there's always more work to do. It's when you are summarizing the world's knowledge, there's always more one could do. But, I think it is interesting, when I started back in 2007, people, poo-pooed Wikipedia, they made fun of it. And then there's, academia looked down on this as a source of information. And then, over the last, 15, 20 years, people's, um, you know, um, um, academics' position on Wikipedia has really taken a 180-degree turn. And many folks within academia now view Wikipedia as one of the best sources on the internet. With the artificial intelligence slop, you know, piling on with these AI programs hallucinating at a 10 to 15% rate, where they say with absolute certainty complete and utter BS, which they have pulled out of thin air. So yeah, I think Wikipedia still plays an incredibly important role. You know, less so for those who are English speakers. As if you speak and read English, the internet, more than 60% of the internet is there for you. However, the world has more than 5,000 languages. Wikipedia is in about 320 languages. And for many languages, there's barely any material in your language. Even for major languages like Odia, a language in India spoken by 40 million people. Urdu, spoken by over 100 million people. Bengali, there's not a great deal of health content in these languages. These are primarily poorer population. So there's not the financial incentive for a business community to go out and try to create this content. So we within the volunteer world of Wikipedia are some of the only folks working to create content in these languages. So that's one of my big efforts right now. Is I'm involved, or I'm the chair of a small NGO within the Wikipedia movement called Wiki Project Med Foundation. So we're one of the thematic organizations, or sort of like one of the chapters within the Wikimedia movement. And we're working on a big translation effort with a bunch of volunteers, volunteer translators, and software programmers to sort of create a way to get healthcare content from English into as many other languages as possible.
That is super cool. Yeah. Did you travel? Do you have to travel for that, or you can do it mostly from your backyard?
Yeah. So I love to travel, just as a hobby. And I often will combine my travels with meeting the local Wikipedia community in that region. So we were in Taipei hiking in Taiwan, and I met with a few of the local Wikipedians there, and sort of recruited them to do translation of healthcare content. So I met a number of physicians who work within Taipei, and I recruited them to do translation from English into Chinese. Did the same in Bhutan, meeting with some government officials who were working on English to Bhutanese medical dictionary, and sort of working on a release of that and how we're going to combine, that translation system into the Wikimedia world. Yeah, so I've met a lot of very interested people, very idealistic people, all these folks who are trying to do the right thing and believe everybody should have access to high quality healthcare content.
I love it. I'm glad. Good on you. Hey, thanks so much for coming on today, James, and sharing your perspectives. A lot of important salient points that I think we covered, and I look forward to some solutions as we go in the months ahead. Are there other big things coming up for you in 2025? Big things you want to note or highlight, or it's steady as she goes?
Yeah. One of the other efforts we're working on within Wiki Project Med is we're working on improving. We're developing systems for offline access to Wikipedia.
Offline.
So we take the existence of the internet for granted. In most of Canada, of course, if you go out to the mountains, or if you try to drive from one city to another, there's a lot of dead zones. But there's many areas of the world where there are fairly large communities who either there's no physical access to the internet, or the internet's simply too expensive. So we develop, assemble, and ship a miniature server. So it's sort of like a computer in a box, and we ship these around the world, and you plug them in, and it generates a Wi-Fi signal. And then anyone within 100 meters of this Wi-Fi signal can log on with their cell phone. And Wikipedia exists within this box. And you can browse Wikipedia even though you have zero access to the internet.
Wow. That's cool. That is very cool. Yeah. All for if you will, a town or a neighborhood or something like that. And everyone could come and gather around.
Yeah. Yeah. So, we've had, we've had orders from Ghana, for example. They had a nursing school that didn't have internet access. So they would put this in their library so that their students would then have access to Wikipedia content. Tonga has no cable going to it. It's a little island in the South Pacific. And satellite internet remains expensive. So, a gentleman within that community bought a number of devices. We mailed them to Tonga, and then, he set them up in the local library, the local school, so that folks would then have access to this material there.
That's great. That is the kind of stuff that makes a difference slowly but surely in our world. So I'm glad that you're a part of it and you can share it with us. Thanks, James. I wish you well as you're doing all your clinical journeys, and I hope to cross your path real soon.
Yeah, likewise. And if you're interested in picking up shifts, you're more than welcome to come to Cranbrook. We'll be happy to put you to work.
I know where I can grab some extra time. Oh my goodness. Yes. That's the
if you're
truth.
feeling underemployed.
Yeah. Cheers, man.